welcome to researchmd.com. Another great presentation. We've been doing a series of lectures on anemia. So we finished, which anemia we finished? We finished microcytic anemia, right? Iron deficiency, anemia, chronic disease, thalassemia. Please go back and review. Great presentations. And all of them under, I think, 15 to 20 minutes, right? So today, we're going to move to the next segment. What is that?
Folate deficiency.
Macrocytic, okay? Macrocytic anemia, and we're going to talk about folate deficiency. My friends, my name is Pramil Cheriyath. I'm a program director, internal medicine residency and transitional residency. I teach medical students and residents on a regular basis, and my friends are here today, so let's start, okay? So we talk about what is the definition of folate deficiency. Somebody read it to me, please, really loud.
It is caused by impaired DNA synthesis, which leads to megaloblastic anemia.
Okay, what is megaloblastic? Somebody right here, what does that say? Somebody tell me.
It's hypersegmented neutrophils.
Hypersegmented neutrophil. How many lobes?
More than 5 to 6.
More than 5 lobes, okay? So I think it's megaloblastic anemia, impaired DNA synthesis, which lead to megaloblastic anemia due to what? Folate deficiency, right? Everybody got that. Now, the next thing is what is the most common cause of nutritional, or maybe we can say most common cause of vitamin deficiency in the United States, right? Everybody agree with that? Okay, what are the causes? We already said like malnutrition, insufficient intake, like chronic alcoholics is very common. They don't usually eat, right? I mean, so vitamin deficiency is very common. Malabsorption, small bowel disease because of the absorption, like celiac disease. When you have a surgical resection of small intestine also is going to be affected. Increased requirement, pregnancy and lactation. That's why we try to do what? Neural tube defect, very common in these people. That's why we give folic acid supplements. So remember, always connected. Something you have to take it out. The folate deficiency is in pregnancy. Big thing. Lactation affected drug, methotrexate, sulfonamides. What is that? Anti-epileptic phenytoin, very common drug we usually use, right? And then trimethoprim. So these are drugs are very important. So what are the clinical features? Usually like clinical features are what? Anemia, very common, right? You can have glossitis, you can have maternal deficiency, fetal spindle bifida, anencephaly, right? And then you can have neural tubule defect and all of those kind of complications and all that kind of later on. So it's very important that everybody understood this part, right? Now we have to think about the pathophysiology. Where does it form? Let's a little bit of biochemistry into this, okay? So what we have to know is there is something called methylene tetrahydrofolate N510. Okay, this is required to convert DUMP into DTMP, so DNA can be made, and there is nuclear maturation. So if you don't have DNA, decreased nuclear maturation, and you have decreased proliferation of erythroblasts, decreased macrocyte. You can form, not decrease, you can have macrocytosis, rapid destruction, that can relate to anemia. So you need this. So some more steps to need to make this one. Let's start over here. There's some methyl tetrahydrofolate N5 over here, okay? That use methionine synthetase and convert it into tetrahydrofolate. Okay, this tetrahydrofolate is then converted to N510, methylene tetrahydrofolate. There's one more step, DUMP using thymidine synthetase. You got dihydrofolate that can also use by dihydrofolate reductase cell can use tetrahydrofolate. Okay, just a little bit complicated, but it's important to know. I will start right here. N510 methylene tetrahydrofolate, convert DUMP to DTMP and make DNA. If this step is blocked, we can have all this macrocytosis, rapid destruction, anemia. Okay, now one other thing you need to know is the homocysteine. Now, homocysteine comes here and combined with methylcobalamin with the use of methionine synthase, make cobalamin or vitamin B12 and methionine, 2 byproducts. Okay, so what happened for this step, in order to produce methylcobalamin, this N5 tetrahydrofolate also use methionine synthetase to make methylcobalamin, right? Let's say if you don't have folate, what's going to happen to this?
It's not formed.
It's not formed. So what's going to happen to this? It's going to be accumulated. This increased. So what does that say over here? Somebody read it. So the lab. So what is the lab you check for? Homocysteine you check. Okay. In this patient, MMA is methylmalonic acid is going to be normal. Okay. That's the way you differentiate between vitamin B12 deficiency and folate. So the lab, of course, increase MCV, right? What is the normal MCV? Around 80 to 100. These people will be greater than 100. And then you have hypersubcutaneous neutrophils, which is megaloblastic anemia, right? And then oral folate supplement, nutritional counseling, pregnant women, give folic acid because you have to prevent neural tubular defect, right? And then if you're contemplating pregnancy, you should take it, folic acid, okay? And then you got pregnant, if it is pregnant female, you just give 600 milligram. I think it's good to know the dosage also. This is only 400 if you're planning to get pregnant, right? This one, and with high risk category, 4 milligram per day PO. This is microgram, don't get messed up. Did it say the milligram?
Yes.
Okay, wrong. So if you're contemplating pregnancy, take 400 microgram, okay? And if you are pregnant, take 600 microgram. Everybody knows that, right?
Yes.
And then if you're high risk, and then you take 4 milligram per day PO, okay? Neural tube defects, okay? You're trying to prevent that. So you can also, can you give IV?
Yes.
Yeah, you can give, like, if this is not feasible, just try to give IV. What is it? I mean, you can give 0.4 to 1 milligram once daily you can give. Okay, everybody understood this? So, definition is like impaired DNA synthesis, megaloblastic anemia, most common cause of vitamin deficiency in the US. Then you think about malabsorption, malnutrition, increased requirement, and the drugs. Just remember about phenytoin, okay, very common drug. And you got anemia, glossitis, and then we come back up here, make sure we know this, the cycle of events happening up here. You need N510 methylene tetrahydrofolate, convert DUMP to DTMP to make DNA. So if this is blocked, all this bad stuff is going to happen, you can have anemia. In order to make this, you need to go another different step. N5-methyl tetrahydrofolate, use methionine synthetase, make a tetrahydrofolate. Okay? And then what happens is, like, you combine there is methylcobalamin and homocysteine, combine it and make cobalamin and methionine. If you don't have methyl tetrahydrofolate, you cannot make this. So this interaction will not take, and you can have accumulation of homocysteine. That's why you got increased homocysteine and normal MMA. Okay? So increased MCV will be there. So you got hypersegmented neutrophils, that is in the peripheral smear, and think about pregnancy, the supplementation. If you cannot give by PO, always give IV. Thank you so much for watching. We'll be back with another presentation. Please subscribe to our channel, greatly appreciate it. Thank you.